2010, the state of Karnataka in India launched VAS, a government insurance program that provides free tertiary care to households below the poverty line. Tertiary care includes a variety of services, mainly dealing with cardiac, oncologic, neurologic, burn, and trauma care. This program had 4 unique characteristics: government contracting with private hospitals, automatic enrollment, patient outreach, and cashless treatment. But why are these important? Government contracting with private sector hospitals meant patients have access to much nicer facilities and are therefore more likely to use them. People were automatically enrolled if they were under the poverty line and lived in a VAS-eligible area, making it easy to get covered. Hospitals under contract organized health camps in rural areas which screened for patients in need of care and transported eligible patients to their centers. Since patients did not have to pay for treatments, VAS significantly lowered out-of-pocket costs and relieved the financial burden of expensive hospital bills. Now let's take a look at the program's implementation. The rollout of the program was designed to allow people who live in the northern part of the state and under the poverty line to gain access to care 2.5 years earlier than people who live in the southern part of the state and under the poverty line. Researchers looked at the extent to which VAS affected the amount people spent on healthcare out of pocket, how often they used the hospital, and the mortality rate among VAS beneficiaries. This information was collected by conducting surveys among households close to the eligibility border. They made sure to study patient populations under similar conditions. For example, it is possible that people in an area with better access to water may have better health outcomes, impacting the results, but they controlled for this. They surveyed villages with similar levels of development to ensure that comparisons were as accurate as possible. Levels of development markers included availability of piped water, electricity, banks, an all-weather road, female literacy rate, and population employed. Over 82,000 households were selected in 572 villages, 300 of which were eligible for VAS and the remaining 272 ineligible. Researchers determined that VAS reduced mortality rates from conditions covered by its services for below poverty line households. In VAS-eligible households, mortality rates were 0.32% as compared to 0.90% in VAS-ineligible areas. There were no differences in mortality rates for above poverty line households. VAS also decreased out-of-pocket health costs by 64%, and people ineligible for VAS died at younger ages than VAS beneficiaries. Patients were eager to share their experiences of the program's positive results.